Okay, I think we'll get going with our second university rounds of the year. I'm Carol Swallow, the chair of the Department of Surgery. And today we have our very important George Armstrong-Peters Prize presentation. So this is one of our biggest departmental awards, and it's given to an early career investigator for outstanding productivity and impact. And I think our recipient for this year is very well deserving on both those counts. So first of all, before we introduce Chris, I'd just like to acknowledge that the land upon which the University of Toronto operates and upon which we are meeting today is and has been for thousands of years the traditional homelands of many Indigenous peoples, including the Anishinaabe and the Mississaugas of the Credit and the Huron-Wendat, as well as the Haudenosaunee. And in our daily lives and our daily work, we seek to do better as we collaborate with Indigenous peoples who still live here, work here, and call this land their home, in order to ensure the sustainability of the land that we all treasure. So next, not very controversial topic at all. We're going to hear from Chris Wallis, who will be introduced by the head of the Division of Urology here at Mount Sinai. Keith, come on up and introduce. Thank you.
It's a great pleasure to introduce Chris Wallis. I've known him for many years. He came through the residency program in Toronto in Division of Urology and did the surgical sciences program. I have to mention Alan Desky at that point because he was a tremendous supporter in the surgical sciences program. And Chris got his PhD at that point. He's been incredibly productive even before starting on staff here. He then went on after that to procedures program at Vanderbilt for his uro-oncology training. And then coming back here, I just yesterday went through the productivity, and it's actually one article every 9 days since he's come back. It says phenomenal productivity. He now told me that not all of those were actually real articles, so maybe one every 10 days. Okay, Chris. So, but been phenomenal. Productivity has been phenomenal. He's also been, if you look at the productivity, though, it's not as though he's just the third or fourth person. He's actually been the driver for a lot of these articles. He's been senior or the first author for a lot of these articles. He's been the real driver. He's also been productive in terms of grantsmanships, been successful at grants. And that's obviously very tough to get even at this stage. And then beyond the academics, at Sinai, he's helped drive the robotics program. So robotics program was started by Chris and the Gynecology Services. And the uro-oncologist in Toronto really helped drive the program in Toronto, drive the program at Mount Sinai Hospital to the robotics program. And finally, he has a family, okay? And I don't know how he does everything. Chris, I'll let you go on.
All right, well, thanks so much. It's a real honor and privilege to talk to the group and share a little bit of the work we're doing. This has been a bit of a labor of love for me. It started back when I was a resident, and this is probably so far about an 8-year arc along this topic. I would say we still have a fair bit more to do. You know, I debated whether I would cover the topic when I had the chance to talk and whether I should just go down a prostate cancer route, but I feel like we would have far fewer people who were interested in attending if I did that. So I want to put this up because I think it's notable. I think what you'll see is that there's a lot of people who are interested in paying me to think about prostate cancer, and essentially nobody who's interested in paying me to think about these topics. So we have a little bit of support from the Sunnybrook AFP, but for the most part, when you dive into these kind of topics, it's increasingly difficult to get funding. And so I think it's just notable. I do want to say, because some people bring it up, I have you could say a conceptual conflict of interest. I have 2 daughters. My view on this subject is that if you have to apply it to your own personal life, thinking about your spouse, your family members, your sisters, or your daughters, you're missing the point. This is a societal issue, and we ought to be doing better for our society, for our colleagues, and for our culture. and try not to anchor on own familial relations. So in that context, the obvious elephant in the room, and the question is always, why am I, who is clearly the least DEI individual in the room, the one talking about a subject like this? And maybe this is just self-justification, but at the end of the day, PhD training, I'm a data scientist, and so I like to go to the data. And this comes from the economics literature. And what they show, and I think lived experience supports this, is that women and visible minorities who support other women and visible minorities are punished for doing so. White men in particular are not punished for their efforts in this domain. And so if we truly believe that there's an issue and this is something that needs to be addressed, at the end of the day, those of us who leverage privilege in society have to use that. So there's a number of caveats in this talk. We're going to go through what I have available to me as data, but that's relatively limited, and it anchors on administrative definitions of sex. And we all know that sex and gender are not interchangeable. And in fact, gender is probably much more important. It drives the way society interacts with you and how you interact with society to a greater degree than sex does, but we just can't capture it. And so it's very poorly studied. The other thing is that this is honestly going to be a very myopic talk, because we focus on sex in isolation. And we know that there's so many other subject positions that matter: race, ethnicity, age, experience, hierarchy, disability. All of these things have individual effects. And then beyond their individual effects, have intersectional effects where they interact with each other. And we're trying to study this, but to be honest with you, it's incredibly difficult. So I'm going to take a step back and say that sex and gender disparities within medicine have been well recognized for decades. So some of these papers date back to the early 90s. We know that women are promoted more slowly, are paid less, have more difficulty with grant capture. These things have been well documented, and I'm not going to linger there because the research program that I have been focused on really focuses on how this applies to our patients and how these differences in the culture of medicine may affect our patient care. And so one of the early studies down this route was by one of my friends and collaborators, Yusuke Tugawa, who looked at patients who were admitted to general internal medicine services in the US. And he's looked at whether the team was headed by a female or a male internist. And what he showed is that regardless of what outcome you look at and how you operationalize the data, there's a small but significant decreased risk of mortality for these patients who have CHF and COPD and other general internal medicine diagnoses if they were under the care of a team led by a female physician. And so I was building a cohort to answer a different question. I built this huge multi-specialty cohort in surgery with the goal of looking at some other things. But this paper came out and it immediately struck a chord with me based on some of the experiences I'd had as a junior resident. And so I thought we should think about this. And I think, we think of ourselves as a bit exceptional as surgeons, and we think that there are things different about getting good outcomes in surgery compared to perhaps internal medicine. So we can think about not just the fund of knowledge, but technical proficiency, communication and teamwork, judgment, when to operate, when not to operate, as well as intraoperative decision-making. And then this obviously all exists in the context of a healthcare system. And so we need all of this. And so at the end of the day, the way we framed our initial question was, how do the postoperative outcomes of patients undergoing common surgeries in Ontario differ according to the sex of the primary surgeon? Now, we built a cohort of about 1.2 million patients undergoing 25 different surgeries in 10 surgical subspecialties. And we matched, and this is clearly imperfect. There's never going to be a randomized controlled trial, at least in my opinion, in this space. And so we do the best we can with what we've got. And so the way we conceptualized the first analysis was a match-based analysis. And some people will think about propensity score matching. This is not propensity score matching. This is hard matching. You have to have exact matches on all these characteristics, not just a distribution of variables. And so we have patients of the same age, sex, and comorbidity undergoing the same operation in the same hospital by a surgeon of the same age and annualized volume of that procedure, whose surgeon differs whether they were male or female. So we can talk about the pros and cons of this approach later, but that's what we did at the time. And what we found looking at 30-day outcomes is whether we looked at our composite, which comprised death, readmission, or complication, or each of those individually, patients who had a female surgeon did better. Across all metrics, outcome rates were lower for patients treated by female surgeons. This was significant for some, not for others. And you can see the magnitude of effect varied, obviously. Now, the absolute rate is obviously driven by the procedures we choose to include. And so there's significant variation there. Some of our procedures, we have appendectomy in there. Mortality rates are clearly not 1% at 30 days for appendectomy patients, but we also have Whipples and hepatic lobectomies and pneumonectomies, and those rates are much higher. So there's procedural variation, and that's why it was so critical that we match procedure to procedure. So if we take a step back and look at a wider picture, obviously, if you're an epidemiology nerd like me, reproducibility is one of Bradford Hill's criteria to try and think about causation, not the only one. So this is every study published looking at the effect of surgeon sex on patient outcomes. This is 30-day mortality. And what you'll see is that some small studies have very wide confidence intervals, but the data really all clusters around about a 5% relative risk reduction in mortality for patients who have a female surgeon compared to having a male surgeon. But we know that short-term outcomes aren't necessarily inextricably tied to longer-term outcomes. And so one of my favorite ways to highlight this is to think of the Berkmeyer bariatric data. So many of you will know Berkmeyer and colleagues in Michigan videotaped surgeons performing bariatric procedures. They blinded those and sent them off to other bariatric surgeons and said, how well is this surgeon performing this operation? Write them on a 1 to 5 scale. And they correlated that with patient outcomes. And so what they showed is that at 30 days, the better the surgeon was on a technical score, the better the patients did. But interestingly, and not a New England Journal paper anymore, is the 1-year outcome, because in the end of the day, it all flattens out. And so this is, I think, a key for our trainees, and probably a good reminder for all of us, is that what you do in the OR, measured under video assessment of your technical skills, isn't the only thing important to get good surgical outcomes. So clearly there's things we do outside the OR that are very important to drive long-term outcomes, things like patient selection optimization and other features. And so that maybe translates into how we think of the causal pathway for physician sex. And so we looked at surgeon sex. This was a paper out last fall. And what you could see is that the outcomes at 90 days and outcomes at 1 year essentially recapitulate the outcomes at 30 days, which suggests to me, when we think of the causal framework, this is not a technical intraoperative thing. This is about processes of care, patient selection, optimization, and other metrics. Now, you may say we're very surgeon-centric. Obviously, this is a surgical audience, but we exist in a wider sphere, and surgery is obviously a team sport. So we looked at anesthesiologists as well. This just to highlight from Julie Halle at Sunnybrook, that there are obvious other examples where anesthesiologist characteristics are important in driving patient outcomes. So she showed, for example, that anesthesiologist volume affects patient outcomes after surgery. So what about anesthesiologist sex? We showed similar effects to our surgical cohort. The absolute difference is smaller, relative difference probably similar. So this is putting all the published literature on physician sex into context. The top half are surgical studies. The bottom half is a mix of internal medicine, anesthesia, and emergency medicine. And what you can see is that it's actually relatively consistent. This is the results for the non-surgical specialties with a relative risk reduction of 6%, and you pull all the studies and you're back to that estimate of about a 5% decrease in mortality in relative terms at 30 days for patients who have a female physician. So we alluded to teamwork already, but what about how people interact with each other? You know, the idea that men are from Mars, women are from Venus is kind of in the cultural zeitgeist, and we communicate differently, and maybe that affects team dynamics in a way that affects patient outcomes. And I would say this is a very reassuring study, particularly for anyone who does administration or has to oversee departments. There isn't an interaction here. It comes out negative. We don't have to think about these factors when we're assigning anesthesiologists to surgeons' rooms, and that's a good thing. But another group in Ottawa at the time, Louise Sun, looked at this particularly in the cardiac space only, and they looked at that interaction between surgeon and anesthesiologist sex. And while overall it was a negative study, they showed that in particular, an all-male team slightly underperformed all-female teams or mixed teams with a longer length of stay. Now, there's other ways to operationalize this. I just want to highlight some other people's work. So this again is Julie Hallay's paper that came out recently. So they looked at the diversity of the team. So this is the combination of surgeons and anesthesiologists in any given hospital and the proportion that are female. And so they picked a cutoff, you can see around 35. And I would argue that we don't necessarily even have to have a cutoff of 35. What you see here is that on the y-axis, patient outcomes, i.e. adverse event rates, go down as there's more diversity. But you could say more diversity, or you can just say a higher proportion of women in the institution. So we have to think about why, right? Epidemiology can find really important observations about the world that then lead us to understand, really impactful truths about life. It can also find absolute red herrings that lead us nowhere. And so biologic plausibility is another one of Bradford Hill's criteria. And we need to think about why this may be true. Why is it possible? And one of the things we've known, you can see from some of these references at the bottom, this goes back 30 years or more in some cases, is that men and women differ in how we practice medicine. So there's communication differences, there's guideline adherence differences, and there's quality of care differences. And I'll walk through a little bit of the data on each of these domains. So guideline adherence, this is not surgical literature. For the most part, this is primary care literature, but patients who have a female primary care physician are more likely to get diabetes testing, get their lipid profiles checked, have cancer screening performed than those who have a male primary care physician. And again, you'll see this New England article is back to the mid-90s. So we have known about this for like 30 years. If you think about how the Institute of Medicine in the US conceptualizes quality of care, this means that female primary care physicians deliver higher quality care than the male physicians. Now, what about decision-making? I think in surgery, this is important. We don't have literature in surgery, but obstetrics and gynecologists are pretty much surgeons. So we can extrapolate from their experience to ours, I think. And what I think is interesting here is they created some hypothetical situations and they asked trainees and staff physicians how they work through it. And what you'll see when you look at this is that male physicians actually relied on their instincts, on heuretics, on just a gut feeling. And female physicians and female surgeons actually relied on data, and they made data-driven decisions more. So what does that translate to? It means that on average, the women were taking a little bit longer, but actually had evidence to support what they were doing, and men were acting a bit faster, but couldn't back it up. And so what you'll see is that this differs in the crisis and non-crisis scenarios a little bit. But regardless, we can see that there are different processes by which different groups of physicians go about making their decisions. Now, everything I'm saying obviously speaks, it sounds like I'm speaking in absolutes. There's obviously distributions within each sex of physicians. So there are women who practice like the average man. There are men who practice like the average woman, and the tails of each of these curves overlap. But we're talking about differences in the means or medians of the populations. So communication, I already alluded to this a little bit, but it's been pretty well documented that men and women differ in both the amount and the style of communication. So we know that in the context of medical interaction, female physicians allow their patients more time, consultations are longer, they're more open-ended, and as a result, women actually get more biomedical and psychosocial information from their patients than male physicians do. And that means, I think, that women are able to understand a patient's priorities better than their male colleagues end up understanding them. So the question is, how does this translate to outcomes? So in surgery, we looked at the interaction between surgeon sex and patient sex. And this is one of the more controversial articles that continues to generate grief for me about a year and a half later. So what we looked at is we looked at concordant and discordant pairs. And so this is to say, you are a concordant pair if the surgeon and the patient are of the same sex, discordant pair if there's a differing sex. Now, we found that sex discordance was associated with worse outcomes. Now, anyone who's sort of thinking is going to say, but that treats a male surgeon with a female patient the same as a female surgeon with a male patient. Those are both discordant pairs. Isn't there effect interaction? And yes, there is. And so that's really important. So you'll see in the top half of this table is that for male patients, having a female physician is associated with a significant but relatively attenuated decreased mortality, second column there. But this effect is dramatically larger for female patients. the order of magnitude is about twice as large for female patients as it is for the male patients. So you see in the bottom line that there is a significant interaction between these two variables such that the magnitude of benefit of having a female surgeon is much larger for female patients than it is for male patients. Now you may say, again, one-off observation. So we went from our 1.2 million Ontario patients, we went to 2.5 million US patients. We did essentially the same study and we found the same thing, and that was published last November. And then we stepped outside surgery. So this is Yusuke Tsugawa, again, one of my collaborators, did this in internal medicine just this spring. It was, I think, released in April, and shows, again, the same thing, an interaction between physician sex and patient sex, such that in particular, female patients are disadvantaged by having a male surgeon, advantaged by having a female or a male physician, advantaged by having a female physician relative to the attenuated effect for male patients. And I think the best data to support this, and I'm going to linger a little bit longer, even though this isn't my study, comes out of the ER literature. So this is not randomized data, but probably as close as we're going to get. This is quasi-randomization, right? The ER doctor you get is not based on your choice or some selection. It's whoever's on call the day you show up. And so these are patients who showed up to emergency rooms in Florida having a myocardial infarction. There are two takeaways here. Number one, the blue line is higher than the red line. So if the ER doctor who was on at the time that you arrived in the ER was a woman, you were more likely to survive than if the ER doctor was a man. Again, supporting the overall body of literature we're building here. Number two takeaway is that blue line is relatively flat. Whether you are a man on the left, a woman on the right, your outcomes are good if you have a female physician. Now, if a male physician is the one on, if you are a man on the left, you do better than if you are a woman on the right. So in close to randomized data as I think we're going to get in the myocardial infarction space in Florida ERs, we see the exact same pattern emerge as we saw on the internal medicine wards in the US, and we saw on the ORs in both Canada and the US. So I think this idea of physician-patient sex concordance or discordance is a real phenomenon. Now, let's think about how we get there. And so there's very little data, but this is an interesting study from Dubai that looked at shared decision-making. And what we see is that this concordance effect actually bears out in decision-making. And male physician, female patient dyads have the lowest shared decision-making of all the dyadic combinations. So back to our prior discussion about communication and engagement with patients, I think this subset of patients, female patients treated by male surgeons, are getting the least engagement and shared decision-making from their surgeons. So if we put it together, there's more to it than just that, though. There are a whole variety of social contexts that I think magnify why this concordance question is important. There's the notion of social proximity or shared identity, and we certainly are highlighting sex in this talk, but there's great data around race here, particularly out of the US, where racialized populations and minority groups benefit from having race concordance physicians due to the notion of social proximity and shared identity. And there's a trust associated with that. So in this context, we can think of a variety of mechanisms, an underappreciation of women's pain, perhaps in the post-operative period that manifests with missing early signs of complications and a failure to rescue kind of mechanism. We can think about sensitive examinations that may be deferred or done in a rushed manner because of some concerns regarding the nature of these. There's certainly societal expectations of women, which mean that I think female surgeons and female physicians in general have high expectations from their patients regarding the nature of communication and how it's going to go down and the amount of time that will be allotted to them. And then there's also not a topic I'm going to dive into a ton today, but there's bias in how we evaluate women surgeons such that they're, I think, probably held to a higher standard than men are. So I want to take it a little bit beyond the patient, though, because we're academic surgeons here. We don't just take care of patients, although it's a key sort of core foundation of who we are. We have to think about the healthcare system, we have to think about research, and we have to think about teaching. And so taking it beyond the patient, last year we looked at the health system implications of these data. And so we looked at healthcare costs. And so again, procedurally matched, patients who had a female surgeon cost the healthcare system less than those who had a male surgeon. So the difference is about $6,000. And that's the, complications, readmission, all those other endpoints we're talking about. They have downstream costs, and we can save about 10% if all surgeons were treated by someone who practiced like a female surgeon. But we can go beyond that. Let's go into the science and research angle. So this is a PNAS study, I think a year and a half ago, showing that gender diversity doesn't just benefit our patients clinically, it actually benefits our science. And so you can see here that as gender diversity increases, and in theory, that actually, you could think of, all female teams being on the left side here, but the reality is there's very few of those. And so we're talking about more integration of women into scientific teams, probably. We see relatively few diverse teams, but when they are there, they're both more productive and they produce more impactful and novel research. And so I think, as I build my career and build my practice, the more people in your research environment who look like you, the more limited you are in your ability to generate novel ideas. And the more the people you surround yourself with look different and think different than you do, the more likely you're going to come up with novel, insightful approaches. So let's take it to teaching. We've got a lot of residents in the room, which is great. The reality is that these social issues manifest in every interaction. So this is the faculty perception. I'll show you resident perception as well. That's the same, but across all steps, you'll see female residents are more likely to be held back, getting less autonomy. Male residents get pushed forward, getting more autonomy. And we break that down. This is the resident perception. And what's interesting is that the faculty recognize this the same way the residents do. This is not a resident perception thing where their perception differs. The faculty and the residents both agree that male residents get more autonomy than female residents. And we can look in this in a few important ways. And I think the most important, and you can tell I think it's important because they made the figure bigger, is on the left side here. So what you'll see is that this is, again, mediated by the staff physician's sex. So where it's a male attending physician, most on the left, there's a big discrepancy where male residents get more autonomy than female residents. When there's a female attending, it evens out. This is, I think, a critical point speaking to if we want to be good teachers, we need to have the teachers represent the teaching population. We need our residents to have teachers who look like them in the same way that our patients need surgeons who look like them. And at minimum, us as men in these roles need to be aware of this data. These are the implicit biases. We like people who look like us, who think like us. It's a natural human phenomenon. You have to actively work to counter that. For what it's worth, it gets worse over time. Junior residents, less difference. As you get more and more senior, the delta grows. So now what? You can either say that this is very interesting or it's very depressing, depending on how you view it. And what, some of my senior colleagues tell me, it just takes time, just like chill out a bit, lay low, let things improve. But people who know me well know that that's unlikely to go over well. So to speak to that in a data-driven way, we've had relative gender parity in medicine for about 20 years. We have a whole generation of physicians who have been trained when men and women are represented equally in medical schools. So if time was going to heal all wounds, it ought to have at least been making some progress. And so I think we need to be a bit more intentional. We need to be a bit more active about this than just saying, we're going to let demographic shifts address this. And so this is 20 years after we hit gender parity. We have 50% of med school applicants being women, about 50% of graduates, about 40% of faculty, about 30% of division chiefs, about 25% of full professors, and less than 1 in 5 chairs or deans. So there's clear attrition where women are not reaching the same levels that men do. And there's 2 ways you can approach this. But I think we need to fix the system. We don't need to fix the applicants. We don't need to fix the women in medicine. We need to fix system of medicine. We need to change our culture. So this is, again, not my data. This is good Toronto data, though. This is Fahima Dosa and Nancy Baxter, who showed, looking at referrals, that there are ingrained biases in how patients get to their surgeons. And so this looked at the effect of referring physician sex on referrals to surgeons. And so what you'll see is that male surgeons get more referrals from both men and women referring physicians, although it's worse among the male referring physicians. And the other thing that's important is it's not just referrals in absolute numbers, it's the quality of referrals. I think we all know there are good referrals and there are bad referrals. There are operative referrals and non-operative referrals. And I will say, I dove into the supplement of this paper again recently. Fahima was so generous. She said that an operative referral was any referral that led to any procedure within 2 years. And in urology, that could be something like a cystoscopy. For gen surg, that could be like an upper GI scope. These are not like, big slam dunk operations. So I think it's clear, particularly to those of us who practice, that women are much more likely to get the undifferentiated abdominal pain with no particular organic explanation. And the male physicians are probably more likely to get the, gallstones who just needs the gall bag out. The men in urology are more likely to get the bladder tumor on ultrasound, and the women are going to get painful voiding with no underlying signs of infection or whatever, right? I think every specialty has its example, but these operative referrals are also dramatically lower for female surgeons than male surgeons. That makes it harder to build your practice, makes it harder to bill. And importantly, back to our last point, this doesn't get better as more women enter medicine or as more women enter surgery, because this isn't a numbers problem. This is a culture problem. And here's a better example of why it's a culture problem. So this is a study done by an economist. And so what you'll see here is that there's a bad event. Actually, at time 0, the surgeon's patient dies. And so what you'll see is leading up to time 0, for both male surgeons, the blue circles, and female surgeons, the red triangles, referrals are increasing. And then after the death, for the male surgeon, the referrals continue to trend up. And for the female surgeon, referrals take a big jump down and then kind of stay suppressed. And you may argue that's actually good practice for referrals to go down to a surgeon who had a bad outcome. Now, we don't want to be all judged on our worst day, but you can see a logic where a referring physician wants to refer less to someone who got a bad outcome from one of their patients. Now, it should happen to both sexes of surgeons, but maybe it's not unreasonable behavior. But what shows that this is unreasonable behavior and a culture problem is that this gets generalized. So this is not just the physician who had the bad outcome. This is all surgeons in the same specialty in the same region. So again, bad outcome at time 0 for male surgeons in that group, things stay about even. But all female surgeons in the same subspecialty in that area experience a decrease in referrals when one female surgeon has a bad outcome. This is a culture problem, not a person problem. So the data as we have it so far is that patients who are treated by female physicians have better clinical outcomes, lower health system costs. In particular, this is mediated by the interaction between physician and patient sex, such that female patients in particular have worse outcomes when treated by male physicians. I think we need to take a step back and consider the whole landscape of surgical care, not just in the OR. We like to anchor on things that happen in the OR, but at least in my conceptual model, you'll see that surgery is pretty late in how we get to surgical outcomes. And there's a lot of things that happen before we get our patients to the OR that are likely impacting their experience and their outcomes. So I want to leave you with a couple of thoughts to ruminate on. What do you think patients want from surgery? They want a good technical outcome. They want to be cured of whatever disease they were referred to. But I would argue they most want to feel safe. And so I'm an oncologist, and I'm going to use an oncology example. This is a really interesting letter. I'd encourage anyone to read it. It's a research letter, 600 words only, JAMA Surgery last year. 7.6% of patients with cancer delayed or foregoed care recommended by their medical oncologist because of patient-clinician identity discordance. If you think I'm making stuff up about this whole interaction between physician sex and patient sex and driving outcomes, like 1 in 12 patients is foregoing care their medical oncologist is recommending because of this identity discordance leading to a lack of trust in that relationship. So there's a couple of people in the room who know this next study. Have you ever been asked as you go into the pre-op area to mark your patient before surgery, did you get a good sleep last night, doc? I think I get it at least a couple of times a week. And we've got 2 people in this room who answered the question, said that we don't need to care, right? Using the same data set that I just showed you in Ontario, thousands and thousands of patients, whether you had a surgeon who was up last night doing an emergent operation, or whether they just had their normal night's sleep at home in their bed and then came in to do your elective case, the outcomes are the same. So patients are worried about this, but we have empiric evidence that it doesn't matter. And yet I just showed you empiric evidence that the sex of your surgeon really matters. So these takeaways are going to seem very detached from the data I just showed you. And I feel like the nice opportunity that comes with getting to give a talk like this, as opposed to when you're assigned a topic, is you get to editorialize a little bit. So the first point is to follow the data. Now, like, torture your data so that you trust it. I sent 3, the first time we got this result, my first paper that landed in BMJ, after we got the results, I was like, okay, this is going to cause a lot of grief. We need to make sure we're right. We can't send this out into the world if we have any doubt. So I took the same data set and I assigned a whole new analyst to it. And I had them do my whole analysis over again, and we got the same conclusion. And then I said, maybe it's the matching that's creating a false result. You know, matching is a hugely restrictive process. You only keep the people you can perfectly match. And so maybe the generalizability is way off. So we abandoned the matching approach and we built a whole regression model, a hierarchical regression with multiple layers. We had patients clustered at the hospital and clustered within physicians, and then clustered within their patient characteristics, and all of that nested within procedures. And the regression models were like to the 100th of a decimal point, the same as the matched models. So once you torture your data and you believe it, you got to follow it. If you trust your data, follow it to its next logical step. And so each of these studies are just built on the one that comes before it. Number 2 is that discomfort is an opportunity to learn. So clearly, as a white guy, particularly as a white guy trying to launch a surgical career, who starts off with all the sort of insecurities that come with not having done a case on your own before. Like, I published half these studies before I did my first staff case. And then I'm trying to convince a patient in clinic that they should let me, with a lifetime independent operative volume of 1, be the one to take out their prostate. And I promise you I'll save your erections. Like, discomfort is part of this. And that's okay. But discomfort is either a chance to back away or a chance to learn. And so I would say there have been 2 reactions to this data. Some of my colleagues are very defensive and really don't like it. And some of my colleagues, I think, have really embraced this as an opportunity to learn. I think Tom Borghese is probably the best example. You guys probably know he's a thoracic surgeon in Utah. He's really, looked at this data and said, this is an opportunity to understand what women are doing differently, how I can pick up those skills and practice in that manner such that I can elevate the level of care I'm giving my patients. That's the goal here. My goal is not to shame male physicians, male surgeons. The goal here is to pick up ways that we can practice differently to give better outcomes to our patients. And number 3 is that it becomes a fine line. If you trust your data, you end up migrating to this line, and it becomes very blurry between science and advocacy. I think the best example, again, I'll anchor in my clinical space, is Mark Litwin is a urologic oncologist who practices at UCLA. And in the 70s and 80s and early 90s, he was studying health disparities for Black men in California. And he showed that Black men were, in particular with relation to prostate cancer, doing awfully. They were dying at much higher rates. They're diagnosed with advanced disease, and they're getting awful clinical outcomes. And so he didn't just publish a bunch of papers and say, that's that. He went to the California state legislature, and at one point in time, he did a sit-in at the California state legislature, and he got them to commit billions and billions of dollars to outreach programs to get prostate cancer screening, testing, evaluation, and treatment out to marginalized populations, particularly Black men. So if you have a topic you actually care about from a research perspective, and you have good data that you can believe in, the line between science and advocacy, I think it's very blurry. I walk it constantly because the trouble is, at least my view, if you go too far down the advocacy road, the next time you start writing a paper, people discount the results of your study because they think you're prejudiced. They think you have a preconceived notion, and that affects the validity of your results. So it's a very fine line to walk. I don't think I've necessarily got it right. I don't claim to have the right answers there, but I think it's a line that is worth considering. So in that vein, 2 last slides, and then hopefully we'll chat. I hope to some degree I've convinced the men in the room that we need to care about this and we need to do something about this. I think if we step outside medicine and look at the business world, if we think this is a problem that needs to be addressed, the involvement of medicine is critical here. I think if you go to the average DEI committee, you see a lot of non-white men. And I think that's natural, but also problematic. Because what we've seen, back to one of the first slides I showed you, is that when men are actively involved in championing diversity, results are better. The companies make more progress when men are involved in this process. And maybe that's self-justification as to why I'm doing this, but I really think it's impactful. Those of us who have power and privilege in society need to leverage it. And the trouble is, like probably most things in life, men overestimate how well we're doing. So there's 2 questions that were asked here. When asked, men are doing everything they can to advance gender equity in the workplace. More than 3/4 of men said they are, but only 40% of women agree. And more concerning to me, when asked whether men in the workplace would be good listeners to a woman who had an experience of workplace harassment, nearly 90% of men said they were, but less than 60% of women agreed. So men here are overestimating our performance. So this is my sort of gestalt feeling on this issue, which is that the responsibility to reduce gender bias cannot fall upon women. Women and men need to be equal partners in championing gender balance in healthcare. And back to one of my prior comments, this is what the research team who does this work looks like. I'm here talking about it, but these are the people who've actually conceptually contributed to the papers that I've talked about. And so I owe all of them a big debt. And now hopefully we'll have some questions.
Thanks very much, Chris. I'm sure there are some questions and some points that people would like to make. Anyone who's online can put their question in the chat. We'll start with a in-person question from Stan Hamstra.
Thanks, Chris. That was really great. When I think of this topic, I think about culture in the workplace. And most of what I saw in your presentation was population level data. But you did mention at one point that you analyzed the data according to hospital in your regression model. So I'm interested in if you saw differences between hospitals or institutions in these results, especially with regard to gender concordance versus outcomes. And if so, what would you recommend for culture change within an institution? I know you touched on that at the end, but, and if not, if you didn't see those differences, why do you think you didn't see them?
Yeah, so it's a great question, just for those people online. Essentially, the question was that, you know, we've looked at population level data, but culture is probably mediating a lot of this. And so looking at it from the institutional culture, I'll tell you that, you know, from the beginning, I was mostly trying to wash out the effects of institutions. I wanted to compare physicians to physicians and take away the effects of the institution was the primary goal. So we're using it really as a clustering feature to get rid of variation between institutions. But you know, I think Julie Hallay's data has highlighted this. The issue, though, is, and so just to reiterate her data, she looked at the proportion of women among anesthesiologists and surgeons in an institution as a metric and showed that as that proportion increased, patient outcomes did better. Now, that doesn't actually necessarily speak to the culture. And I think there are certain institutions where the proportion of women is actually low and yet maybe a positive culture. So we've got some work that's not published looking at high performing versus low performing regions and institutions, trying to understand that. The other thing we're doing, and I alluded to it at the disclosure slide, but not afterwards, is that Sunnybrook AFP has provided us money to actually do a qualitative study that complements all this quantitative work. So this is going down the mixed methods approach. So we've hired an anthropologist who has been at 6 or 7 different U of T hospitals, following surgeons around, watching them in clinic, interviewing surgeons, asking them questions about, you know, how do you make decisions? What do you prioritize? How do you, you know, elicit priorities and values from your patient? How do you collaborate with other surgeons? When do you think about involving other medical specialties in the care of your patient? So we actually just finished data collection September 26th for that study. So we're doing sort of the thematic analysis that comes with doing qualitative research, and hopefully that result will be probably early 2025. We'll have some qualitative research to complement the quantitative.
Okay, one more from live, David Urbach.
Thanks. I love the slide with the book, Change the System, Not the Women. So can you talk a little bit about like some of the system changes that are contemplated for those of us who are interested in policy or you know, organized approaches to try and address this problem with what's out there, and why isn't it succeeding?
So it's a great question. The one line answer is that I don't have all the right answers. The bigger context is who I am means that I don't have the lived experience of all of the culture problems. So I, as I've kind of alluded to, try to use my position in society to raise this as an issue. I try to find ways to empower people, I think, who have lived through the problems of our current medical culture to voice their solutions. I would say from them, I've heard a variety of things. I think one of the ways that'll obviously be music to your ears in terms of the referral bias is some notion of centralized referral. The idea that women are disproportionately getting referrals that are impediments to building their practice is an issue. And so after, you know, you were at the CSF with me, after our talk, one of the general surgeons came up to me and said, we just moved to centralized referrals. All my male colleagues are really unhappy because they're seeing all these referrals that they don't want to be seeing. My volume of these undesirable referrals have gone down. These undesirable referrals are now spread throughout the group, and my male colleagues are really unhappy because the GPs weren't sending those to them before, and now they're getting all this vague abdominal pain that they don't want to be dealing with. They just want the straightforward hernia that needs to get booked for the OR. So, you know, that's one example. I would say that I am not the right person to tell you all the ills of medical culture and how we should fix them, because I haven't lived through the actual weight of those problems.
Okay, somewhat related from Anissa Nazir online. Such an informative presentation. What do you think is the role of mentorship in improving gender parity in surgery and culture change?
So I think there's a huge role. I think to some degree, and again, I don't profess to have the answers here. You're just sort of getting my personal opinion, not, you know, some best evidence. But I would say, you know, my view is it's hard to be what you can't see. So both in terms of caring for our patients and training our learners, we need a representative surgeon workforce. The better our surgeon workforce represents the populations we're serving and those who we're trying to train, the better we're going to do. Now, to get from where we are today to what that looks like, there's going to have to be people who don't look like those populations serving as mentors to get those people there, right? The first woman in surgery was not mentored by a woman because that's not possible because she was the first. And so we need men who are willing and able to mentor women, and understanding that their lived experience is not going to be the same as ours. Their priorities may or may not align with ours, and many times they may, but don't make assumptions that your view on how a career should evolve necessarily fits with how your mentees should. And I think as long as you have that flexibility that your identity may create different experiences for you than your mentee has, I think it's important. I also, for what it's worth, I do urologic oncology. This is a very male-centric subspecialty of surgery. I go out of my way to try and like put additional mentorship efforts into anyone who shows interest who doesn't look like me. Not that I don't give any help to the white boys, but I try and help those who don't look like me.
They need the most help. Andrea Cavalli?
Thanks for sharing, Chris. As you know, I feel quite passionate about this topic as well. When I agree with you when we say we can't just wait for the system to change, and really we have to think about how we change within that culture. And we've seen some things around cultural safety and competency come out. So the SANIAS course for the Indigenous population, that was now a course through the Black Health Education Collaborative, looking at this for our Black patients and cultural safety for them as they enter into healthcare. And these courses are being distilled at both the leadership levels, you know, the clinician levels, and even at the medical student level, to try and address how we think of cultural biases as we come up through the system, as opposed to a top-down approach. And I guess any thoughts, or do you know any work that's being done around these inherent biases, specifically when we think about sex and gender?
So it's a great question. The short answer is no, I don't. But I think you've alluded to a bigger issue. And I was, scrolling one of these physician Facebook groups this morning, and someone was bemoaning the fact that a non-white physician or a non-white patient had walked into a practice and asked for a relatively sensitive topic to be seen by someone who looked more like them. And there was talk of, reverse discrimination. And I think it's really important for us that have privileged positions in society to understand that our patients, our learners may not feel comfortable. There's an implicit power differential here. And if someone feels uncomfortable with us, that is not their burden to bear. We have to accommodate. I don't think we can think of this as racism. If a racialized patient says, due to the experience that either I've had, my family members have had, or my ancestors have had in the healthcare system, this is not someone I feel comfortable with. That is fair, valid, and reasonable. And what we need to do is change, broadly speaking, as well as individually, how we practice such that the next time they come forward, maybe they will feel more comfortable. So I do think we need those programs, and it behooves us to just be open to the fact that we need to accommodate the lived experiences of our patients and our learners. It also applies to.
Okay, a couple more online now from Bhishma Ravi. Thank you for an interesting talk. I wonder what your thoughts are around the impact of residual confounding, particularly when dealing with such large sample sizes. I think a general rule of thumb when dealing with population level data is that an effect size of 0.3 is in either direction could result from residual confounding. Do you want to talk about that?
Yeah. So, I think it's reasonable. I alluded to this when we put up the matching slide. There is no perfect study here. I don't think there's ever going to be a perfect study where we randomize patients and we say, you're going to have a hernia repair. We're going to, sign the consent. We'll flip a coin and you'll get either a male or female surgeon. Beyond that, to account for the study design we've accounted for, we'd want to account for physician age and experience and physician volume. And so to build a big enough cohort of surgeons, let alone patients, to be able to do that kind of study, I think is not feasible. Now, the question is, could this be residual confounding? The answer is always yes. It could be residual confounding. I think there are a few things that speak against it. And you can think back to Bradford Hill criteria and think through the 8 or 9 criteria, and I think we're satisfying most of them. So I think a couple of things that speak against residual confounding. Number one is that the reproducibility of this across different contexts in which different residual confounders would be anticipated is important, right? The confounding that would come in a surgical context is different than would come perhaps from an internal medicine context or the ER patient showing up with a heart attack. The confounders you can imagine are there in all studies, but they're not the same. So the fact that we come out with a relatively consistent and homogeneous signal in spite of these different study contexts, study designs, I think speaks to an underlying biological effect. Although we always have to be open to the idea that, I think we could think about the fact that we're capturing surrogates. And I think what I've tried to highlight is we're trying to capture surrogates. I don't believe that the presence or absence of a Y chromosome inside the physician treating you is leading to worse outcomes. It's about the behaviors that are happening, right? How male physicians on average practice differently is leading to the outcome. So is there some other surrogates we could capture that explain this away? I think yes, but that's on the causal pathway more so than confounding.
Okay, another online from Jeannie Richardson at Trillium. Women taking more time, seeing more consults to build a practice, et cetera, takes its toll, particularly as these differences extend across other areas of life outside work. Any research that looks at burnout, health outcomes, and correlation to less women in advanced career roles?
Yeah, so you know, there's a ton of like this topic is so broad to try and capture it in 40 minutes is a bit ambitious. There is a lot of research here. So there's recent studies in JAMA surgery that have actually shown that women in surgery in particular are more likely to go part-time and more likely to leave medicine than men are. And I think that's a variety of things. I think, as I've alluded to, I think the expectations within medicine and within surgery are in some ways higher on women. Women are held to a higher standard, have a greater time commitment asked of them, have on average in return for that time commitment, lower remuneration. So we're getting, you know, much lower value for spending more time for less income. And then, you know, to speak to wider societal biases and issues, women have a greater sort of second shift burden, right? There's the work expected when you leave work is also higher among women. On average, male surgeons and male physicians, their partner is going to take on a greater proportion of the homework, and female physicians and female surgeons, when they go home, on average, are bearing a proportionally much higher burden of that workload. And so I think you're getting that burnout phenomenon on both ends, and any reasonable person has to balance that is going to have to cut down somewhere. And if you don't have a spouse that can step up, you got to cut down on work. And so, you know, that means that you get women going part-time or leaving the workforce.
A couple more live questions. Andrew Howard.
Thanks so much, Chris. I think this is excellent discussion. And you didn't spend a lot of time on the gender pay gap, which Natalie Anshar was writing about in the CMAG this week as well. But thinking about what we do in academic hospitals and the fact that we can model stuff, like we can try stuff out. And we could think about either our incentive structure, because it seems to be wrong. We're paying more to get less. Or we could think about our teamwork culture. And I may be kind of leaping to conclusions here with assumptions, but if you had to place a good bet on either or both of those, what do you think we should do here structurally, policy-wise, in our hospitals to start to set the environment better?
So, I mean, you started off your comment on the pay gap, and I think it's more concrete and perhaps a little bit easier to address. I mean, at the end of the day, in our current models, almost all of us are fee-for-service, which is to say the higher volume you put through, the more money you make, right? And what that means is that the more straightforward your consults are, i.e. those direct operative referrals, not the undifferentiated pain, is remuneratively beneficial. So those referral distributions drive pay differences. The cultural expectations of our patients for more time with women hurts their pay. And we've seen in the US that if men and women spend the same amount of time with patients, i.e. women spend less time than they would, necessarily, they actually get hurt. And here we tend to not care about it, but in the US, Press-Ganey scores are a big deal. Female surgeons' Press-Ganey scores drop if their time with patient is equal to male surgeons. And to get equivalent Press-Ganey scores, they have to spend more time with their patients. And so there is a pay component that comes with that. We talked about this at the CSF a couple of weeks ago. One of the options here is a salaried model, and a salaried model actually has to be detached from productivity. So even most salaries in the US, at least, are tied to productivity-based bonus structures. But productivity-based bonus structures are all predicated essentially on the same fee-for-service structure where doing something generates more bonus. And we have to acknowledge that, someone like me who can see, a ton of elevated PSA patients in clinic, and each one takes me like 8 minutes, like maybe I need to see 10 of those, while my female colleague sees like 5 undifferentiated abdominal, pelvic pain, burning kind of patients. Those are going to take longer. We're both providing a value to the community, and maybe those should be compensated similarly. So, that's one approach. And I think in academics, there's an additional layer there, which is that a model like that allows us to explicitly and financially value academic and educational time efforts, which are in large part not funded at this point.
So testament to how interesting this topic is. We have a lot more questions. I'll give the last live question to Tom Forbes and then one final closing statement. Tom.
Thanks, Carol. Very thought-provoking, lots of questions that I'm sure are still unanswered, and it's a good thing you're at the start of your career because you've got another 50 years or less to answer some of these. So I wanted to expand on one of your comments, just maybe one of the answers that you gave, that it may not necessarily be the X or the Y chromosome that drives the differences that you're seeing, that may be some feature of practice or skill or knowledge that is not absent in males, but at least more common in females. So I guess the next challenge is to identify what that secret sauce is, and then how do we make it pervasive across all surgeons? And maybe that requires changes in our educational priorities. Maybe it requires changes in our reward structure. Maybe you can comment on that.
Yeah, so I mean, fundamentally, I agree with you. And I think this is one of the reasons why we've done this study with this anthropologist to try and observe and survey physicians to understand how they practice, why they practice, and what they prioritize. And I think the goal is to identify those differences in behavior such that it is teachable. There is a behavioral intervention trial plan that theoretically comes out of this work. We need to figure out what the behavioral intervention is. The trial is actually easy to design. You need to figure out what your intervention is, though. Now, the issue, I guess, more broadly is that, there's a nature-nurture phenomenon here. There's certain characteristics and behaviors in the way you interact with people that are socialized in to men and women a little bit differently through the way we have been brought up. And to some degree, to address these, we probably need men to adopt skills that have been coached into little girls from the time they were like 3. And it's not necessarily that straightforward to take a 40-year-old guy and say, hey, all these implicit messages you picked up for the last number of decades have led you a little bit off the path. Now come back with us, right? Like, that's the theory. I'm not so sure how successful I'm going to be.
Okay, I'll just read a statement from Najma Ahmed. So to close this off, with respect to the topic of science, allyship, advocacy, there's an important tension, one we cannot ignore. We need to learn how to better advocate for the patients' populations we study and serve without the scientific weight of the work being dismissed. Physicians and scientists have always advocated for healthier societies, smoking cessation, seatbelt laws, etc. Fine line you refer to is when we should learn to walk more skillfully. So I think, as often is the case, Dr. Ahmed has hit the nail on the head with the greater, broader implications of the work you're doing, Chris. Congratulations again on your award, and thank you for a great talk. Intense. Yeah.
Thanks so much.
Thank you. Thank you.